Okay, so this morning, what we want to do is talk a little bit more about some pathologies associated with the nervous system. Specifically, we're going to talk about cerebral vascular diseases. In other words, factors that affect the nervous system from blood vessel disorder of some sort. So basically, the general category that we're going to start with today is to talk a little bit about stroke. Stroke is sometimes suggested to be referred to as a brain attack, much the same way that we talk about heart attacks, to give a better visualization of what's actually going on with the pathology. Because we've got two major types of strokes. The first one is the so-called brain attack type, where which is described as an ischemic stroke. By now, we should be comfortable with the terminology ischemic. Ischemic is telling us that the tissues are unable to receive enough oxygen. So basically, an ischemic stroke is due to a sudden blockage from an artery that supplies the cerebral hemisphere. So it's going to be from a cerebral artery, sudden onset from a cerebral artery blockage. We're going to have to review a little bit about, or learn a little bit about, these cerebral arteries in just a moment. So when we talk about a blockage, we're talking about some sort of a thrombus or embolism. And most typically, when it embeds itself in one of the cerebral arteries, it's left the heart through the carotid arteries. And you may recall that there's a common carotid artery, both on the left and the right side, that splits into an internal and an external branch. I'm going to show you a picture of that in just a minute. But the internal branch is the one that's ultimately going to supply the cerebral hemispheres, specifically an anterior cerebral artery and a middle cerebral artery. And we'll see about a posterior cerebral artery when we look a little closer at the actual blood vessel anatomy. So this thrombus formation would come from atherosclerosis, and the embolism from the heart / carotid artery pathway. So what happens basically when it leaves the chamber of the heart, it enters the aorta, that's a big vessel. It enters the common carotid, that's a pretty big vessel, and then progressively branches as distribution through the brain occurs to a smaller artery that's going to be blocked. The embolism will not be able to continue through. It blocks blood flow beyond that point. And as a result, there's going to be loss of oxygen supply to the neurons that artery was supplying, and we're going to see the results of that. So that's going to lead us to an acute ischemia. So with that word acute, we can appreciate that we will be talking about a sudden onset. So the symptoms are going to present in an acute, sudden way. And it's going to be ischemia to the areas supplied by the involved and we know what that means. It's a progression. Decreased oxygen delivery to a cell is going to result in abnormal ATP production, certainly reduced ATP production. That's going to lead us to abnormal sodium, potassium pump function. That's going to lead us to cellular edema, cytotoxic edema is possible in the nervous system, rapid loss of function. All of this means decreased function, and it's going to be noted within seconds. About a minute is the length of time that these neurons can survive without this oxygen supply. And it will be irreversible within a few minutes. So what's going to happen in the 2 to 3 minutes with no oxygen leads to infarction. And that involves necrosis and apoptosis of the cells that are involved. And since these cells, by and large, cannot be regenerated, they're going to have to be replaced. They'll be replaced with scar tissue. And this process may take a few hours to occur. So in other words, it's going to be visible on examination of the brain tissue, the area that's been absent of oxygen. The surrounding tissues that are maybe not completely devoid of oxygen, but with less oxygen supply because of collateral blood supply. And we're going to look at that blood supply in a minute and see some of that collateral blood supply, is described as a penumbra. So the treatment goal is to save these cells. So try to establish a more adequate blood supply to that surrounding area to prevent that penumbra from developing into full-blown ischemia. And the treatment plan early on, with this in mind, is to try to bust the clot, thrombolytics. Now, another thing to be aware of with respect to these types of patients who may or that may be an indicator for being at risk for this type of ischemic stroke is something that's abbreviated as TIA. Some of you maybe heard of those. That's an acronym for transient ischemic attacks. So this is a situation where there's the signs and symptoms of a stroke that last from a few minutes to maybe over a 24-hour period. Okay, but usually not any longer than that to be classified as a TIA. And this used to be sort of a standard indicator for an ischemic stroke. In other words, this was a warning indicator that an ischemic stroke was impending. Now we understand better with imaging and that sort of thing that the any evidence through better imaging that we have, any evidence of an infarct is an indicator that there's already been a stroke. So transient ischemic attacks were temporary, we'll call it brief signs and symptoms of central nervous system ischemia. But last thing, so to give you an indicator of the time that we're talking about, minutes to hours, but seemingly reversible. In lots of cases, it tends to present and is reversible unless imaging shows infarct. Infarct is telling us there is dead cells and those will no longer be functional and typically not replaceable. So we're going to be left with some degree of impairment, as minor as it may be. So we know that this is an important warning for thrombosis. So the prevailing understanding is that a transient ischemic attack occurs when a small thrombus is blocking a small area of supply to the brain, but is broken down before it results in complete infarct and complete ischemia to that group of cells. So it's an important warning for thrombosis or thrombotic disease and equals an increased risk for ischemic stroke. Okay, now remember, risks are not causes. There's a big differential there, but most stroke patients I shouldn't say it that way. Let's fix that. About 30% of stroke patients had at least one TIA previous. And again, not a percentage that you need to memorize, but understand that that's a pretty significant indicator if 30% is the number we're talking about. So in patients that have had a history of transient ischemic attack, we can provide some preventative treatment, just like for heart attacks, daily aspirin. And if the blockages are significant, interventions like angioplasty for blood vessels that are plus or minus 70% blocked, which is otherwise a narrowing that's described as being a stenosis. Reduced blood flow due to the narrowing of that blood vessel. Okay, so what about these blood vessels? Let's take a quick. I'll show you a nicer picture in a minute. But what we're going to do is show the cranium, and the cranium will look something like this. So we've got our just to give us an idea here, we'd have our vertebral cervical vertebrae there. So if we want to follow the two main blood vessels that supply the central nervous system within the skull, the internal carotid, and the vertebral artery. Okay, now the internal carotid artery is an artery that's going to travel anteriorly in front of the vertebrae. It's a branch. The common carotid branches off of the aorta on the left and off of the subclavian artery on the right, more than we need to know for now, and is going to travel and branch. And the internal branch is going to enter the cranium internally, so we're not going to worry about the external branch. The external branch is going to supply structures on the outside of the cranium, and the internal branch is going to supply structures within the cranium. In other words, the tissues associated with the brain and the brain stem. So we're going to follow our internal carotid artery into the skull and through in front of the brain stem primarily, and then branches off to supply a major branch to the front part of the cerebrum. So this one is known as the anterior cerebral artery. And coming off the anterior cerebral artery, we're going to have a branch. I got it a little bit high, but it'll serve us. This branch is going to supply structures associated with the eye. So again, we're not going to really, it's called the ophthalmic artery. If you saw the name ophthalmic artery, you should be able to figure out that at least it has something to do with structures associated with the eye. So the anterior, so this is our anterior, and it's got a branch that comes off it that goes to ophthalmic, but also travels to supply the structures that it's most closely associated with. So it's going to distribute through the frontal lobe of the cerebral cortex and share some collateral circulation with the parietal lobe and so on. And then a branch that's going to be coming off nearby, I'm going to show you a better art, is another contribution to the cerebral area, is referred to as the middle cerebral artery. And that's this one right here, middle cerebral artery. And that would be the one that's going to supply, we're going to list all the general responsibilities, but this would be supplying the hemispheres that it's most closely associated with. So if we're this view here, if this is anterior and this is posterior, most of us should recognize we're looking at the right side of the face and skull, and therefore we're looking at the right cerebrum. So basically what we're saying is that there's going to be a right and a left of both the anterior and the middle cerebral based on which side we happen to be looking at. So right now, all of these would be right-sided. So we're going to have the anterior cerebral artery has the territory of the frontal lobes and shares a little bit of collateral circulation with parietal lobes. So if you remember, frontal lobe is about cognition and so-called executive orders and recognizing consequence for action. So if there's a blockage in this anterior cerebral artery, we're going to have interference with those types of functions. And we would see some sensory loss as well. We'll talk, I'm going to fill this out for you in just a minute. When we look at the middle cerebral artery, this is more associated now with parietal and temporal regions. So we're going to see, if it was left-sided, we would see effects on speech. Remember, 90% of the speech would be left-sided. If it's right-sided, it may have more to do with pathologies associated with spatial recognition and that sort of thing. But basically, that's what we're talking about there. When we talk about the second major artery that is going to be supplying structures in the brain, it's the vertebral artery. And the vertebral artery passes up through the transverse processes in the vertebral of the cervical vertebrae, and then enters the skull behind the internal carotid, and is going to branch to head sort of posteriorly to form what's called a basilar artery. The basilar artery is going to pass, join together with the right and left vertebral arteries join together to form the basilar artery. And that basal artery is going to travel with the brainstem and enter the central parts of the cerebral hemispheres and gives off our posterior cerebral artery. Our posterior cerebral artery is going to look after structures just like it sounds in the posterior cerebral regions, as well as an occipital. So we would have over here, let me get the color here. Posterior cerebral artery. We would have an occipital artery. We would have the basilar. And that's joining of right and left vertebral arteries. So from this side or so-called lateral view, I just want you to get the idea of the contributions from the anterior, middle, and posterior, and that especially as tissues age, we're going to have a collateral circulation, branching that helps to share oxygen delivery to the various parts of the brain and the skull. So this posterior cerebral artery is a branch that comes off of the internal carotid as well. And then off of the vertebral artery, we've got this collateral circulation. So we're going to have these additional circulations along those lines. So there's a branching and sharing of the responsibilities. I've got a picture here. Let's look at a cleaner version of this. Before we look at that one, let's look at this one. So in this diagram here, we can see that we've got the blood vessel that's traveling in front of the vertebral column is our internal carotid artery. And as it passes up into the cranium, it's going to branch into an anterior cerebral artery that is going to share some distributions with both the frontal and the parietal lobes. The middle cerebral artery for parietal, temporal, and branching posteriorly. And then we have, not shown in this diagram, we would have a branch of our posterior and down in this corner, we add in the vertebral artery. Vertebral artery passing up through what's called a vertebral foramen in the cervical vertebrae, and then enters the skull in the cranium. And together, these two arteries, the internal carotid and the vertebral artery, are going to form a series of joins, if you like. The fancy word is anastomoses. They connect to one another to form a circle. And that circle is described as being the circle of Willis. And so here we have a picture of the circle of Willis. And this represents the vertebral artery posterior to the right internal. So the opening of this blood vessel represents the right internal carotid artery. You can see that there's a right one and there's a left one. And coming off the internal carotid, we've got our middle cerebral artery. We've got our anterior cerebral arteries. Okay, and the branches that come off let's show the circle. The circle is going to be formed from branches that are described coming off of both the internal carotid artery and the vertebral artery. Okay, and then we have our posterior cerebral arteries that are a combination of branching from the internal carotid and the vertebral arteries. Here's our basilar artery. So the two vertebral arteries, right and left, join together in front of the brain stem to form the basilar artery. These branches just represent branches that are going to supply the tissues they're most closely associated with. So there would be midbrain pons and medullary arteries that supply those parts of the nervous system. We can appreciate that the anterior cerebral artery is going to look after the anterior cerebrum, middle cerebral, and posterior cerebral. And off of the posterior branches and the right, this happens to be right, posterior communicating branches, we're going to supply the cerebellum as well. So it's just regional from a distribution point of view. So our signs and symptoms of the ischemic stroke will depend on which blood vessel is involved. So we had our anterior cerebral artery, and it supplies the frontal lobe. Which means that any kind of blockage would result in abnormal cognition. Remember, this was the executive decision-making centers of the brain. If it's left-sided, we may see aspects of speech affected. And on the opposite side, we would see some sensory loss. Remember, the right side of the brain is responsible for sensation on the left side of the body and vice versa. So there's going to be a crossover. So the opposite side, the fancy word for being on the opposite side, is the contralateral loss of sensation. So these are responsibilities of the anterior cerebral artery. If we talk about the middle cerebral artery, the region, the territory that the middle cerebral is responsible for is the lateral cerebral hemisphere. So just think again what's involved there, including deeper down in this region are the basal nuclei. So loss of function of neurons from this region is going to give us some opposite side, contralateral, partial paralysis, hemiplegia. We would see some sensory loss. So again, if the stroke was left-sided, these would be presenting on the right side of the body. Again, aphasia, think about the location for Wernicke's and Broca's areas for speech. And again, those are primarily when it's left-sided. Right, we said left-sided there to be clear. We may see some visual disturbances because what's passing through this area is the chiasma, where the crossover for vision is occurring. So that's why there could be some visual disturbances and so on. So again, just be generally aware of the structures that these regions have responsibilities for. So if we're talking about the posterior cerebral artery, now we're in the occipital lobe. And also the medial or temporal, right? There's going to be overlap. That's why we need to be, again, aware of the anatomy. And if we have posterior cerebral blockages, then we're definitely going to have some visual pathology, because that's where the primary visual cortex is located. We may have some memory pathology, and that really would apply to all three of these areas to some degree or another. And I should mention, this middle cerebral artery is the most common site for an ischemic stroke. Most commonly involved is the middle cerebral, and you can appreciate why. I'll show you at least one of the reasons why this would be the case. If we look at the pathway of blood flow through the internal carotid artery, the natural direction of blood flow, the volume of blood flow that's going to pass through the internal carotid artery is going to pass into the middle cerebral artery. So if we think blood flow is coming up through, there's no real turn or kink in blood vessel direction from the internal carotid artery to the middle cerebral. You can see that for the blood flow to get to the anterior cerebral, it has to go through this little anterior communicating artery. And if it goes posteriorly, it has to go through a posterior communicating artery. So those are branches that require the clot or the embolus to turn a corner. So it's more likely going to flow the area of least resistance, and that happens to be this middle cerebral arteries. So that's why it happens to be the most common location for blood clots to present. Now, if we take a look at the basilar and vertebral arteries, we're thinking about the location that those arteries are going to be found. The vertebral arteries join together, right and left, to form the basilar, passes adjacent to the brainstem. At the top of the brainstem, we have the thalamus. So we're looking at thalamus together with the posterior cerebral branches of the basal artery are also going to supply the cerebellum. And of course, as we've mentioned, the brainstem. So involvement here, reduced blood flow or absence of blood flow to these areas, is going to result in abnormal gait, loss of cardiovascular and respiratory regulation. Think about the medulla oblongata. The gait is cerebellum, and so on. So all of these are just really basic summaries of what you could expect to find. But understand that the whole point of this little slide here that we're looking at right now is to understand that these blood vessels have regions that they're responsible for. And if there's a clot in any of these regions, we're going to have loss of function for what those regions were responsible for. So when we look at treatment, specifically for the acute injury, we need to, our primary responsibilities are to try to minimize the size of the involved area. So minimize the infarct size. And we ultimately would like to be able to preserve So the issue is that early on, it's very difficult to differentiate between an ischemic stroke and a hemorrhagic stroke. And yet it's important as soon as possible to try to make that differentiation. You'll see why. But on the physical exam, the presentations are often very, very similar. So we keep in mind that we cannot differentiate an ischemic stroke by anything early on. So we're going to need a CT scan, right? The CT scan or a CT angiogram is going to be necessary in order to confirm a blockage, right? That's what's going to be the confirmation. So a CAT scan So those are our two options we have in order to try to confirm, because treatment is different. You can appreciate that if in a hemorrhagic stroke, which we haven't yet talked about, it's a bleed into the nervous tissue, and blood is toxic to neurons. So that's where the symptomatology is going to come from. In the case of an ischemic stroke, it's a block in a blood vessel. So the neurons are not being exposed to toxins from blood, but they are being exposed to ischemia. So the presentation, as far as the neuron's concerned, is going to be very similar, but the treatment is going to be very different. So time of onset. So basically, we've got options in the early stages of onset that will not be made available or be effective if we're late to the party. So in other words, if we can get to the stroke and understand that it's an ischemic stroke within the first 3 hours or so of onset, then thrombolytic medications are going to be effective. Early intervention. So let's say 3 to 4 hours. So the thrombolytics can still be effective. Remember, there's going to be loss within minutes. What we're trying to do is reduce the overall effect. So that's where we're trying to address the penumbra, the groups of cells that have reduced blood flow. Introducing the thrombolytics is designed to try to minimize the infarct size and as a result preserve those neurological functions that we wrote down at the top of this page. So there's also a surgical intervention where we can go in, surgeons can go in and actually try to remove the blockage. And that's a situation where within, if an institution is equipped and has the talent, in other words, has the surgeons who can do this kind of thing, then it can be an effective treatment within 24 hours or so. And that's a situation where either the clot is going to be tried to be dissolved surgically, or a stent can be applied, just the same way we talked about bypass stenting stenting in cardiovascular disease. The same concept applies with some of these cerebral arteries, if that's again, if it can be applied based on the equipment and the skill level within the facility that the person has presented to. So the whole goal of the thrombolytics, or within 24 hours, is to try to minimize that ischemia that causes hypoxia in the cells. And of course, what we're trying to do with respect to reestablishing blood flow is to regulate glucose and other considerations. So we also need, in terms of follow-up, so we'll say, again, part of the early interventions, regulate glucose metabolism, make sure there's glucose available for ATP production. Manage temperature. Everybody, I hope, understands what we mean by that. If we're talking about managing temperature, if we can reduce body temperature or prevent if there's a raised body temperature as part of the reaction to the ischemia, the goal of managing temperature by reducing it reduces demand for ATP. So we want to decrease body temperature to reduce demand. So anybody that's presenting with an ischemic type stroke that also has fever and hyperglycemia has a poor prognosis, a worse prognosis under those situations. Okay. And again, because this is an ischemic stroke, anticoagulation medications can be effective, especially if the symptoms seem to be progressing. Now, the key thing here is you have to monitor for hemorrhage, since it's not uncommon for an ischemic stroke to lead to or be converted to a hemorrhagic stroke. Think about the buildup of pressure behind the blockage. If the blood vessel's at all weak or under the pressure from an arterial hydrostatic pressure, it may cause a rupture, a hemorrhage behind that blockage. So that's something to be aware of as the symptoms progress. Okay, for hemorrhagic stroke, we've kind of established that sometimes the symptoms can be very similar, but basically when we talk about a hemorrhagic stroke, the most common reason is rupture of the blood vessel secondary to hypertension. So patients who have high blood pressure are at risk of hemorrhagic type strokes. Other considerations? Those that are on what we would call systemic anticoagulants. So they may be people that have been at risk for blockages, and so they're on anticoagulant therapies, and a group of medications that are called sympathomimetics. Any mimetic is mimicking another, whatever's put in front of it typically. So sympathomimetics are going to mimic epinephrine or norepinephrine. In other words, they're going to promote the fight or flight response more or less. So people that have chronic low blood pressure might be put on a medication that's designed to try to raise that blood pressure. So these are sort of background factors that could be a reason for why someone would be subjected to a hemorrhagic stroke. These are a relatively small percentage of most strokes are going to be ischemic in nature. So maybe 10 to 15% of all strokes are going to be described as, that leaves us with the other 85 to 90% being the ischemic type. The problem with these is that they have a higher mortality rate. And a higher morbidity rate. In other words, if they survive the stroke, they've got more significant long-term sequelae, more symptoms that are irreversible, even though they may have, so they may be left with paralysis or left with speech impairments and those sorts of things. So again, sudden onset. This is the approach this is the part of it that makes it difficult to differentiate. We're going to have some focal pathologies initially. Remember, focal was local to the area of the bleed in this case. We would probably see increased hypertension, increased intracranial pressure. That we know is going to present with a headache. And that may progress to loss of consciousness. Okay, so the arrows are just indicating a progression that we can see here. In the elderly, they often develop these amyloid plaques in blood vessels that weaken those blood vessels, make them more prone to rupture. When the hemorrhage is large, we're going to get that increase in intracranial pressure. That increased intracranial pressure can lead to herniations that we've talked about already. Those herniations have typically a poor prognosis. They're going to often result in death. The prognosis is ultimately dependent on the volume of the blood mass, age of your patient, location of the bleed, and rate of compression onset. So in other words, how fast the bleed is applying pressure, creating those herniations. So remember what we said was we need a CT angiogram to confirm the diagnosis. So we know hypertension is the most common underlying factor, so management of blood pressure is important. Reversal of the anticoagulant treatment. Oftentimes, in an emergency situation, anticoagulants might be being administered before it can be determined whether or not the source of the problem is hemorrhagic or ischemic. So the anticoagulant reversal may have been applied because 90% of the time, that's the type of stroke that you would be being faced with. So it may have been administered early on. So if that's the case, that's got to be corrected. Surgical removal of hematoma is also an option. It depends on location, depends on how stable that is or appears to be, and that sort of thing. So one of the most common mechanisms for a hemorrhagic stroke is through aneurysms, cerebral aneurysms. And cerebral aneurysms (95%) occur within that circle of Willis that we described, within the circle of Willis. So we'll go back to that circle of Willis as a quick review. Circle of Willis is outlined in yellow here. So we have contributions from the vertebral arteries. Remember, our vertebral arteries and the two internal arteries, carotid arteries, are the ones that contribute to the circle of Willis. We've got anterior communicating branches, and we've got posterior communicating branches that join those two main arteries in each case off of the basilar artery to form that circle of Willis. So when we talk about ruptures that can occur within the circle of Willis, I'm going to just draw locations for you so you can appreciate locations. So one of the most common locations is kind of at the junction between the anterior cerebral arteries and the communicating arteries that go forward from there. So this region right in here. Now keep in mind that when we talk about an aneurysm, it typically is going to result from a weakening of the blood vessel, causing an expansion, and the concern with an aneurysm is that it may rupture, increases the possibility of a rupture. So in this case, this is described as, well, this is probably one of the more common locations, about 40% of the time. And again, not a number to memorize, but this is the most likely location for a circle of Willis aneurysm to occur. So it's just at the junction or close to the anterior cerebral artery. That's the part you want to remember as far as that goes. Another relatively common location is off of the middle cerebral artery. So we would have let's make sure I stay with my color. And we'll just keep the blood vessel membrane there for now. So that's a little less common, but almost equally as common. So you would have this one as 1. We can have one that comes off of that junction just between the internal carotid and the middle cerebral artery would be the number 3. Okay, and even I'm not going to ask you a question about 1, 2, 3, or 4. I just want you to get an idea of where these are most likely to occur if they're going to occur. And then rarely we can get an aneurysm that forms off of the sort of the superiormost part of that basilar artery. And so it would show up in this region here, and it's pretty rare. But we have common locations, and these are due to connective tissue weakness. So certain individuals who have underlying factors like Marfan syndrome or Ehlers-Danlos syndrome or other kinds of endocrine pathologies that may result in weakening of connective tissues, put those patients more at risk of these blood vessels weakening. And you can appreciate that the part of the reason that the circle Willis is susceptible here is because the blood vessels are under relatively high pressure and they're pretty small blood vessels overall. So under high pressure, arterial pressure, they're not that far away from the heart and the larger blood vessels. So the pressure is pretty significant. So we said that cerebral aneurysms, the bulk of them are going to occur within the circle of Willis, and we just showed you some of the locations for those. Most of the time, so they start out as dilations, but there's a risk that they could fracture. So they're going to be asymptomatic. Typically, sometimes patients might have a sense that there's a little pressure in a location. It might present as a bit of a headache, but it's nondescript and not something they typically would probably go and seek some attention for, unless the rupture is impending. In other words, there's been an event that's resulted in a bigger ballooning or a bigger expansion on the blood vessel, and that's creating some symptoms. But oftentimes that's just before a fracture or a rupture is going to occur. So females are a little more at risk than males, 30 to 60-year age group are a little more common. There's about 3,000 or so presentations in Canada per year. Who else is at risk? You can appreciate that smokers are more at risk. Alcohol use puts you more at risk. My abbreviation for alcohol. We mentioned earlier sympathetico, empathomimetics. And if there's any kind of family history, And that may indicate some underlying, maybe even an undiagnosed connective tissue issue, that sort of thing. So the most common sites for these ruptures are within those sort of communicating arteries, especially the anterior one, as we listed. So what's actually going on? The most common shape, most common type of aneurysm is described as being saccular, and saccular is sometimes referred to by a guy's name, Barry aneurysm, and that refers to a blood vessel that ends up with an expansion. If it's saccular, it kind of expands like that. So that so-called Barry's, and that's due to a weakness in the tunica media. So the muscles of the middle layer of the blood vessel are getting weaker. And we mentioned that the most common location was circle of Willis. Any location where there's turbulence increases the risk for that sort of thing. So at junctions between branches of blood vessels, hypertension, so we say that the primary that really represents the pathogenesis there. So sometimes patients will get a little indicator that there is an impending rupture going to occur. They're described as sentinel leaks or warning leaks, and they may present with a severe headache. But basically, if you get any kind of actual rupture that's going to be rapid, remember it's an artery, so it's under high pressure, sometimes known as or sometimes described as a thunderclap headache, just really emphasizing the sudden onset and the severity. Sensitivity to light, so it's photophobia is a fancy word for that. So that's all describing a progression of severity. And certainly patients who go through a hemorrhagic stroke go through a lot of this exact presentation. So a very common cause of a hemorrhagic stroke is a cerebral aneurysm that ruptures. It's the number one cause for a subarachnoid hematoma. So we can just, we'll put that in, number one cause for subarachnoid subarachnoid hematoma. So again, what are we concerned about after the rupture? The bleed results in an increase in intracranial pressure, increase in blood volume within that subarachnoid space, and that's going to give rise to ischemia from vasoconstriction compensation. So what are we going to do for treatment? Obviously, I hope it's clear, this is an emergency. The rapid onset and the severity makes that pretty clear. So one of the things that we have to consider is we want to reduce blood pressure in order to minimize that's going to require intervention in an institution, a hospital, obviously. Some aneurysms are accessible by surgery. In either case, the hematomas, aneurysm, the hematoma needs to be removed. That may require a craniotomy. We can fill the aneurysm, since the most common sites of aneurysm are in the circle of Willis, because it's a circle, right? If we have a circle of blood vessels, let's just draw in our basilar and our posterior, our middle, and anterior. So if we have if we block this with surgical blocking to prevent that weakened area from continuing to bleed, we block that area. Because it's a circle, we can reestablish blood flow in all of the branches through pathways. So if normally we would see that our pathway would travel this way to get into this blood vessel, but that's been blocked now because of a surgical intervention. But we can still get it all the way around and back in this way. So that's the beauty of treating a blood vessel associated with the circle of Willis. So we can also, so that's referred to as fill the aneurysm, since most are associated Now, another consideration that can result in a weakened bleeding into the brain and be our less common source of hemorrhagic blood supply, or hemorrhagic stroke, I should say, is what's known as an arteriovenous malformation. AVM. So this is the number 2 cause of a subarachnoid hemorrhage. So what we have going on in this situation is that someone is born with this malformation. So the onset of a rupture is going to happen in a slightly younger population. So usually a diagnosis is going to be made under the age of 40. So there's an embryonic formation of an arteriovenous shunt. So there's no capillary beds in between. So basically what happens is you get a combination of blood vessels that are sort of coiled over one another, coiled around, whoops, that's supposed to be. So it's a combination of arteries and veins with no capillaries in between, and the blood vessels tend to be a little bit weaker. So there's an increased pressure from the arterial side to the venous side with no capillary distribution in between. So the veins become enlarged due to the constant pressure that's being applied to them, and they become weaker over time. So the hemorrhage is initially manifested in about 50% of these cases, and a small percentage by seizure. And then an investigation is going to have to be undertaken with a suspicion that this type of thing is what's causing the underlying signs and symptoms. So in other words, if it's a seizure initially from pressure before a hemorrhage, but most commonly the hemorrhage is going to be the initial presentation. In other words, patients won't know that they have this malformation until symptoms are occurring, in other words, too late for any kind of prevention to occur. The other issue that occurs with these patients with an arteriovenous malformation is they have what's referred to as a vascular steal. In other words, what's happening because there's no capillary network, there's no distribution of oxygen and nutrients to the neurons in that particular location, because we went right from arterioles to venules with no distribution in between. So there's a vascular steal. We're stealing the oxygen and nutrients from those particular cells. So that is a local ischemia in the nearby nervous tissue. So the one thing to consider then with this malformation is that there's an increased pressure in the arterioles that gets distributed to the venules that causes expansion and weakening and puts this patient at prone to fracture or rupture. And the second thing we mentioned is that there's going to be some local neurological ischemia. In 50% of the cases, actually, let's change that. So 50% of the cases are not going to be understood or recognized until there's been a hemorrhage. And a smaller percentage may present with seizures that get investigated. So in the case of treatments, surgery, if the location, radiation, so basically what will happen with radiation therapy is designed to destroy the blood vessels, block them all up, create scar tissue, and promote redistribution, corollary circulation around that area to replace what would be missing otherwise.